Hello and welcome everyone to tonight's Orthopaedics webinar focusing on paediatric fractures and scoliosis. I'm Dr. Leonie Harcourt, a GP Education Advisor at the Capital Health Network. Also with me tonight is Kanal Mohiti, the Events Lead at Capital Health Network, and of course our expert speakers, orthopaedic surgeons Dr. Igor Policinski and Dr. Jerry Lin. We were also going to have paediatric orthopedic specialist Dr. Braze Wardle speaking tonight as well, but he's been called away, so we'll have to postpone the talk on gait abnormalities. So first, we'd like to acknowledge the traditional custodians of the land we are meeting on, the Ngunnawal people. We acknowledge and respect their continuing culture and the contribution they make to the life of this city and this region. And we also pay our respects to any other Aboriginal and Torres Strait Islander people who may be attending tonight's event. So before we start the presentations, just to let everyone know that you've been muted, and if you have any questions, Dr. Lin and Dr. Policinski are happy to answer them at the end of their presentation. So please type them into the Q&A box on your Zoom screen and not into the chat box. And just to let you know that also we will be putting up the recording onto our Capital Health Network YouTube page. If you missed something, you can go back and find it, but we'll also send the slides out to attendees. So our first speaker tonight is Dr. Igor Policinski. Igor will be talking about common pediatric fractures. Igor's clinical work focuses on treating conditions related to the hand, wrist, elbow, shoulder, and to trauma. He holds fellowships from the Royal Australian College of Surgeons and the Australian Orthopaedic Association. And in addition to his clinical work, Igor is dedicated to advancing the field through research and education. So thank you very much for tonight. This is part of it. He actively shares his knowledge with junior doctors, registrars, and other healthcare professionals like GPs and allied health professionals through lectures and training. Igor currently practices at Brindabella Orthopaedics in Deagon, where he offers comprehensive upper limb care to private, public, DVA, and workers' compensation patients. So thank you very much, Igor, and over to you.
Thank you very much. I'm just going to start sharing my my screen here and do this. Can everybody see the screen?
Yes, that's good.
Perfect. Okay. Thank you for letting me talk today. My talk is pretty broad. It's about pediatric fractures. It talks about upper limb and lower limb and some other fractures as well. But I'm going to concentrate primarily on fractures that are seen by GPs or primary care providers that you might come in contact with, especially if it's a follow-up fracture from the Canberra Hospital or any other facility. So just a couple of things about me. Yep, I work at Brindabella Orthopaedics, and I've been in Canberra for now over 10 years. I've done some fellowships in hand and wrist surgery as well as shoulder surgery. And I've done also some hip and knee fellowships in Wagga Wagga. Right now, I'm a trauma surgeon at Canberra Hospital, and I also am a registrar supervisor, and currently still the AOA ACT branch secretary. All right, so with this talk, I wanted to talk about the anatomy of the child because they're a little bit different than adults. I also wanted to talk about the different types of fractures and then some fracture follow-up, especially in the GP sort of setting that you might see. So what we're going to do is I'll just break this down into the anatomy. So the children's anatomy is a little bit different than adults in that they have primary and secondary ossification centers. And those ossification centers are where the bone is being formed, and as the child grows, the bone expands and grows, both longitudinally and in the width direction as well. And so the growth occurs at the physis, okay, and we have also the epiphysis and the apophysis, which are areas. I'm just going to point here. I don't know if you can see my mouse button, but it's where there is insertion of tendons. Can you, Leonie, can you see my mouse button, my mouse hovering?
Yep, I can see the mouse.
Okay. Now, the other very important thing about pediatric bone is that it's got a very thick periosteum, and the periosteum helps the bone growth and gives it stability, as well as blood supply. So when we talk about primary ossification centers, okay, these start in the fetal life, and they usually start around the second trimester, and they grow, and that's where the bone forms. So the new bone basically starts forming by deposition of blood cells, and then you start having a sort of primary ossification center appear on in the fetus. Once the fetus is born and becomes a neonate or a child, then secondary ossifications appear, and we can not see them initially on the X-rays, but we can find them and see them on the ultrasounds. Okay, and they usually occur in the long bones. They occur in the on the shaft at the proximal and distal end. So this is an example. For example, in the ossification centers on the left, you can see the fetus. You can see some bones that have formed, and that's the primary ossification center. On the right, on the other hand, you can see the secondary ossification center. For example, in this, on the right side of the hip, you can see the hip ossification center, which is normal. So this is a normal hip ossification center, and this child's probably a little bit more than 12 months old, because you can already see it. But on the left, you can see that the ossification center hasn't formed. So something's not right with this ossification center on the left side. It hasn't formed completely. And then that's when we would get either an MRI or an ultrasound to have a look what's going on. So the other very interesting part about children's bone anatomy is the growth plates, right? So this is where you've got different types of zones of cell proliferation, and where they are formed. Okay, so there's quite a few zones. You can see that's histopathological slide, basically, with lots of blood flow. And the important zone that we sort of are interested in orthopedics is the hypertrophic zone. This is where the cells are maturing very fast. They're growing really fast. And when the child breaks the radius or femur or tibia, and they get a Salter-Harris injury, this is where the injury comes from. So these cells are very quick at proliferating and healing. So when they do get an injury, within a few hours, that zone starts to heal and starts to deposit new cells. So with Salter-Harris injuries, we have only like 48 hours to 72 hours to get in there and do a closed reduction. Otherwise, it starts to heal, and we can re-injure the hypertrophic zone if we delay, for example, by a week, a Salter-Harris injury. Now, what about the other fractures that children get? They get sort of bendy bones. They get green stick, and they get a little bit of like a plastic deformity. And the reason for that is that in the child's bone, there is more Haversian's canals around than in an adult. So you can see that. And they basically become more bendy. And so the osteoid that is around the Haversian canal normally fractures or cracks through here. But in the child, it actually bends. So they have a different type of pattern of fracture when they do break something. All right. So that's a quick summary, sort of, on the anatomy of the children's bone. It's interesting because it's different. Now let's talk a little bit about different types. I'm going to go through some of these very common fractures that you might see, and then we'll talk a little bit about the follow-up and the management of these fractures. Okay, so the most common, you will see that very often, is called a buckle fracture. It's very common, usually fall off a scooter or from a monkey bar, and when you get an X-ray, you can see that there's a little buckling on the distal radius here, and that's why it's called a little buckle. So the bone just basically buckles under the force, and it leaves a little expansion or little change. And so with these fractures, there is actually more and more evidence to show that you can actually just bandage them, and you don't need to put them in a plaster or a splint or anything like that. But the normal bandage or a stockinette is enough for them to heal, and they won't displace. So usually you don't need any more follow-up. You just take one x-ray and give it 4 to 6 weeks. Once the child's pain-free, that's all they need. So that's all good, and the literature supports that, and there is studies to show that this is coming up. But it's actually managing, for me, like when I see these buccal fractures, it's actually managing the parents is the hardest part, because it's reported as a fracture, and then if you tell them you're going to put them in a bandage rather than a plaster or a splint, it takes a lot of effort to convince the parents that this is all they need. And sometimes putting on small little wrist splint or removable brace is better for them. Everyone's happy, and the child's happy, and the parents are happy. And to be honest, it's not going to harm the child if you put in a splint or even a short arm cast if they're very active, rather than putting a bandage on. So yes, there is literature about bandages and treating these, and that's good. But be reasonable, I guess. If you get a fracture, you can put it in a splint or a short arm cast, and they won't have any problems having that kind of treatment as well. Normally the cast, if I do cast them occasionally, like children with ADHD and they're a little bit more hyperactive, they do get a cast from me. They go in a cast for 6 weeks, because I want that fracture to fully unite, and when they come out, they can pretty much do whatever they want. If they're more reasonable children that are less active, then 4 weeks of splinting or casting is all you need. Next, we'll move on to green stick fractures. Okay, so green stick fractures are fractures that are a little bit more complete to a buccal fracture, and they usually fail from the force on one side. So you can imagine when the child falls, the wrist goes backwards, okay, and the fracture occurs on the volar side here. And there is still a buckle on this side, but it hasn't completely torn. Hasn't torn the dorsal aspect. And that's also where the periosteum comes into play, because the periosteum is very thick. So on this side, the periosteum, on the dorsal side, it will be intact. So it acts like a hinge. And so these fractures usually tend to be with more force, like a push bike accident or a playground equipment type of injury. And usually they angulate, and they require a closed reduction. Very rarely, if it's, for example, a both bone forearm fracture, they would require some wires. When we put them into plaster, we usually mold it so that the plaster is molded to the fracture. It's a 3-point mold so that it stays well reduced, and the plaster keeps it in position. Now, changing the cast, or what type of cast should we do, whether you do an above elbow or a short arm cast, that's sort of, again, very surgeon dependent. I prefer to put the child in an above elbow cast, because I feel that if it's going to move, it's going to move. And if we put an above elbow cast, it's the most immobilized arm that they can have. And children don't get stiff, so they don't really, after this type of fracture, I wouldn't expect the child to get stiff and lose motion. If I would do that to an adult, that would cause stiffness in the wrist. But children usually don't get stiff, so they will regain the motion. So putting an above elbow cast is not a problem for a child. And again, 6 weeks, that's how long usually these fractures tend to heal. Now, we do a check. So this is maybe where you might come in as GPs. You might see these children with casts on, and usually we do a check at the pediatric fracture clinic at 1 week and then at 2 weeks, because that's the time that these fractures tend to displace. Even if they're minimally displaced and we accept them without a closed reduction, we're going to monitor them, because they can fall back out of alignment, and then we would have to do a closed reduction at a later stage. And then at 6 weeks, we do a final check, make sure that there's plenty of callus and the child can come out of the cast and get the arm moving. So what is acceptable for angulation? So sometimes we can't get these perfect. And again, this is the biggest time consumer for us to talk to the parents and explain to them that 10 or 15 degrees of angulation is actually completely acceptable, because children have a a huge amount of remodeling potential, and I'll go into that a little bit later. I'll show you some slides about that. So, you spend a lot of time just telling patients that it's fine, it's going to be okay. You just keep on monitoring, keep on watching it. So for the dorsal angulation, we can even accept up to 18 degrees, and the younger the child, the more we can accept. For the volar angulation, so if the bone is tilted volar this way, we accept approximately 10 degrees. So this is what I've sort of been talking about. The remodeling potential is massive in children. The younger they are, the more remodeling it is. So you can see this is a neonate on the left side. This is the broken humerus, probably from delivery, okay? And heaps of callus. This is at 2 weeks, okay? And then at 6 months, pretty much the bone has remodeled, and you can't even see that they had a fracture, okay? Same thing with this. This is an older child. You can see the physis are there. You can see the growth plates. So this child's probably about 8 or 10. They had a mid-shaft fracture. It looks terrible. You show that to the parents, and the parents are like, oh my God, well, why are you not fixing it? Why are you not putting a plate? But then you leave it, and then at 3 months, the whole thing has remodeled. The whole thing is united. You can even see the length of the bone, even though it's a little bit short here. When you look at the wrist, it's actually equalized. So some bones like femur or the ulna have a overgrowth potential, so they can actually grow faster because of all the stimulus that has occurred. They will actually grow faster, and they'll catch up to the short. When they have shortness, they can actually overgrow that defect. All right, now we'll go into a little bit more complete fractures. So these fractures are completely displaced, so we call them sometimes offended, okay? So these are usually less stable, and it all depends on that periosteum. So we call it a periosteal hinge, okay? And we teach our registrars that this periosteum that's on the top of the wrist is really important, because you're relying on that hinge to keep the fracture stable when you do a close reduction. And occasionally, very rarely, but occasionally when we do a close reduction, this can break and the fracture becomes really unstable, and then it needs a wire or some kind of stabilization, okay? Now, there are other types of complete fractures, for example, elbow fractures, so condylar fractures, okay, or supracondylar. I'll talk a little bit about that as well. And then there is forearm mid-shaft fractures, which look terrible, and then you got a femoral shaft fractures. So, these are all fractures that are complete and displaced. So, most of the time when there is a pattern of injury, we already have a plan for them. So, for example, for this one, I would probably not attempt at a close reduction, because these intra-articular fractures, also called Salter-Harris 3 or Salter-Harris 4 fractures, will not stay in position. So these fractures don't stay in position, and you need to reduce them perfectly so that the joint inside, which you can't really see the cartilage on, is perfectly aligned. So this will need to be opened up and reduced, open, and then wires are usually inserted. When you look at the middle image, it's a complete fracture. You would think, oh my God, this will need to be, fixed. Let's put a plate or maybe some nails into it to make it, straight. And same thing with the femur, how are you going to fix that? So I'll go through each case and I'll show you what we did and how it varies. Okay, so like I said, a lateral condyle fracture, you can't really try close reduction. It doesn't work, so you got to open it up. So there is some K-wires holding it nicely. 6 weeks, the wires are left proud, and we pull them out in the clinic. The wires don't hurt coming out. Now, for example, the shaft fracture, we thought, oh, we might have to plate it, we might have to put nails, but we try and we attempt a close reduction in the operating theater, and you can see how well it aligned at the end, and it healed perfectly. So we consent the patient and the parents that, we might have to open it up or put some nails or plates, but we always try to do a close reduction first, and we rely again on the periosteal hinge. Okay, so the periosteum hasn't ruptured, and therefore it can be treated in a plaster. Okay. Well, for example, in the femur, the periosteum is gone. This is unstable. Basically, you can't control the rotation. You can't control the thing, the alignment. And so we opted for putting some nails in. These are flexible tense nails, but you could do a plate. You could open it up and put a plate on it, or you could choose to put the child in traction. And as long as the leg is pointing in the right direction, 6 weeks in traction, and the child's femur would heal with a massive amount of callus. And then just like the humerus, it just remodels with time. After about 6 months, you wouldn't even see that the child had a fractured femur. The difference between these is that, with the nails, is we can get this child up and about, maybe on crutches if they be able to get around, or get them home. While traction, really, the child stays in for 6 weeks in traction in the hospital, and it's a bit of a nuisance. They get pressure areas and things like that. So we still do some tractions and treat femoral shaft fractures with tractions, or we plate them, or we put nails. It also depends on the weight of the patient and the size of the patient and the age of the patient, of course. Okay, what about unstable fractures? Like, for example, this one. So we tried a closed reduction. It didn't work. It has an unstable pattern, almost like a rotational pattern. And also the ulna has been fractured. So that makes this fracture very unstable. Okay, so we opted to put a plate on it. And so the plate goes in and stabilizes the radius, and the ulna sort of reduced itself. But again, you can put this child into a short arm cast, and the ulna will heal perfectly, and the radius is held well with a plate, so it doesn't need any further immobilization apart from the 6 weeks until the ulna heals. The question is, what do we do about the plates? Do we leave them, or do we take them out? And I'll talk a little bit about these a bit later in the talk. Let's talk a little bit about Salter-Harris injuries. So these are growth plate injuries. Okay, so this is a classification Salter has come up with, and it's divided into 5 different types of fractures. The first one and the 5th one is extremely rare. You probably wouldn't see these. The second, very common. It's the most common type of fracture, where the fracture starts at the top of the bone and then goes through the growth plate. The type 3 is an intra-articular fracture that enters the joint and exits through the growth plate. And type 4, just like the lateral condyle fracture that we've seen before with the K-wires, is a type 4 fracture where it starts at the shaft and then continues on. A type 5 is a compression type of fracture, but those are very, very rare. So again, they occur. We talked a little bit about that growth plate. Okay, so it goes through the hypertrophic zone, and so there is problems with that. There can be growth disturbances if the fracture disturbs the growth plate and that zone. There can be problems later down the track, and we'll talk about these. Okay, so for example, this is a type 2 fracture. Okay, little fragment fractured off. It just needs a closed reduction. Occasionally we need to put K-wires into these to stabilize them even more, but usually 6 weeks of casting, and that's all it needs. Now, if you try to manipulate this, for example, after 3-4 days, if you try to do a closed reduction, it's almost near impossible, and you have to go in and you have to open it up, recreate the fracture through the growth plate, and then do a closed reduction. And then, because you've created a fracture, you might have to put wires in, which is not ideal. That's why with these Salter-Harris injuries, we want to get them in and get them done the same day or the next day, and really get them going. Okay, so always look for a Salter-Harris injury, and they need to basically be referred immediately to the hospital so that they can have the manipulation as soon as possible. Again, there's a couple of Salter-Harris injuries here. You can see the distal radius. The radius has completely fallen off. Okay, and then we've attempted a closed reduction, but you can see it's already at 1 week, or this is at 5 days. It's already slipping, so you can see that it's going backwards and it's coming off the bone. Okay, so we had to take the child back, okay, and then remanipulate it. We hate doing that, but if we have to, we have to. But then we got to watch these children and make sure that they don't get any growth arrests, because the growth plate can arrest where the wire is or where the injury was, and they can have growth disturbances at a later stage. This one we've talked about already, but I'll show you some growth disturbances, okay? So for example, here, you can see that the ulna hasn't been fractured, so it looks perfectly normal, okay? Something's happened to the growth plate, so there's a growth arrest in the growth plate here. And again, this is usually after Salter-Harris 2 or 3 type of fracture. And maybe a wire was put in, but whatever caused it caused the growth arrest. And you can see how it's overgrown because the ulna keeps growing. The distal radius hasn't, and they get changes as well. The joint line itself doesn't look too bad, but it changes the kinematics and the appearance of the wrist. And correcting these type of deformities is very difficult because they're three-dimensional deformities caused by a growth plate injury. This is another type of Salter-Harris injury. We call it a triplanar fracture. This is a very specific type in that the fracture goes through 3 different planes. Okay, so you can see that. And these also can be associated with a growth plate arrest. The good thing about these fractures is usually it occurs in children that are a little bit older, in sort of 12 to 14, and they're about to fuse the growth plate. So even if the growth plate does fuse somewhere, they don't get such big growth plate disturbances and growth arrests. It's the worst ones are if it occurs very young, like 9 or 10-year-olds, then we really got to watch them. Now we talk a little bit about supracondyls because these are very common type of fractures as well. They're usually monkey bars injuries. When they fall, the child usually falls with an outstretched hand. There are different types of classification. So we've got 3 classifications for the extension type, and then there's also a very rare type. It's called the flexion type. These are highly unstable and require fixation as well. So type 1 is usually a fairly undisplaced fracture. Type 2 occasionally needs a reduction and K-wise. There is it's divided into a couple of other types in that it's got a bit of rotational instability, and type 3 is usually a complete off-ended supracondylar, like you can see down here. So this is a type 3. Again, we're relying on the periosteal hinge, so you can imagine that the periosteum here is going to be intact. The front one has been completely torn, but the back one is still intact. Okay. So normally what we do is we take them to the operating theater, do a close reduction maneuver, and percutaneously put 2, sometimes 3. Sometimes we've got to go medial as well, another wire on the medial side to get stability. Occasionally, these type of fractures can be open, like this one. So you can see that the humerus has come through the skin, and it's basically an open type injury. This is an injury that needs to be taken to theater immediately, and this has a very high chance of either an AIN palsy, so anterior interosseous nerve palsy, or a posterior interosseous nerve palsy. So we always ask the child to give us a thumbs up and also flex the thumb. And if they can't do that, that means that they might have had a nerve injury. So again, we take them, give it a wash, do a close reduction, and percutaneously fix them. You can see that there is also a medial wire on the inside here and 2 lateral wires to give extra stability for this fracture. And in this type of fracture, I suspect, but it might not be, the periosteal hinge at the back has been ruptured, so it's fairly unstable. Okay, so I'm going to go into a little bit more specific type of fractures. These have usually some names associated with them. So Seymour fracture, open phalanx, distal phalanx fracture. So they can occur in the foot, okay, when the child gets the foot caught on a corner of the bed, or sometimes it can occur in the fingers as well. So you can see this is the bottom image is the X-ray of a finger, and the the injury has occurred through the growth plate of the distal phalanx, and it's an open injury. So there's a nail bed injury. You can see how swollen and red, and there's a nail bed injury. So these injuries need to be washed out, gone to theater, washed out, and they need to be reduced. And usually we put a little wire into it to hold it in place. These are like Salter Harris type 2 injuries. So basically, but it's an open injury. So it's gone through the growth plate, and they're very typical in the digits, and also in the feet and in the hands. And children usually get antibiotics, and they get a wound check usually at 1 to 2 weeks to make sure there's no signs of infection. And the wire usually gets pulled out at week 4 because of the growth plate potential. The growth plate just heals so quickly that we can pull the wire out at 4 weeks. Okay, so I'm just going to talk about principles of fracture follow-up. So this is, again, with buccal fractures, they're the easy ones. You can put anything on them, really, just even a bandage. And 3 to 6 weeks, once the child's pain-free, that's all they need. They can start moving it, no problems at all. No x-rays necessary and no follow-up. There's no growth plate disturbances, nothing that you have to be worried about. If you're going to have a fracture, this is the one to have. All right, now what about other ones, the more displaced or the more angulated ones? So usually they go into a plaster. So you can see this plaster on the right hand side is very well molded. Okay, so there's big mold here. Okay, so the plaster doesn't look great. Children and parents are like, oh, why is my plaster so deformed? And the reason why we do that is we mold the fracture, 3-point mold, to keep it in its position. Okay, now ideally we would like to keep these for 6 weeks, and usually my preference is, when the registrars ask me, can we change a cast at 2 weeks to a waterproof cast, I say no, because the chances of it falling and displacing are pretty high, and then you end up with a angulated radius, and just because you wanted to give them a waterproof cast. So I usually try to encourage children and parents not to change casts because the risk of the loss of position. At 6 weeks, we usually take the casts off and get those children moving. And if the fracture itself initially is not displaced or angulated, then, well, you can put a waterproof cast, and it can be a fiberglass waterproof cast for 6 weeks. But again, you would have to check it at 1 week, 2 week, and at 6 weeks, make sure that the fracture is not moving. Okay. If they do get some wires, okay, for example, a supracondylar or a condyle fracture, usually we take those out between 4 and 6 weeks. That's also depending on the surgeons and us looking at intraoperative stability. And normally I tell all my patients, except for buccal fractures, really, that they shouldn't do any contact sports for about 3 months after the fracture. So there is 6 weeks in cast, and then another 6 weeks of no contact sports, but they can engage in swimming. They can start bike riding if they want to, and children are pretty active, so they keep themselves going. But contact sports usually I reserve for the 3-month mark. Lower limb fractures, they take a little bit longer to heal, like femoral shaft fractures, and it depends on, again, the age of the patient, but I usually start weight bearing them at 6 weeks, and then these sort of children progress themselves. They start walking on it pretty much when they can tolerate. And so it's hard sometimes to give them guidance of partial weight bearing or touch weight bearing. That they don't really listen. So once we decide we're going to weight bear them, you got to be 100% sure that it's going to be okay. So usually 8 weeks might be a little bit better because the fracture's healed up a little bit better than starting to weight bear them at 6 weeks. If they do have hardware, for example, tibial hardware or femoral hardware or any other hardware, normally the best time to remove lower limb hardware is around the 6-month mark. Sometimes it's got to stay a little bit longer, but you don't want to leave it for too long. Like leaving it for 2-3 years, the child's bone will overgrow the hardware, and then there's massive difficulties taking it out. Contact sports for lower limb, I usually tell them to start at 6 months. So I keep them without contact sports for a while. Now, removing hardware, for example, for upper limb, I take it out a little bit earlier, usually by between 3 and 6 months, depending on the child's age and how well the fracture has healed. So upper limb, usually, non-weight bearing bones, they can have it out a little bit earlier. So again, going back to the wound check. So when we do 1 and 2 weeks, what do we look for? We look for the alignment, displacement, and we compare the X-rays. That's why it's important to have X-rays of what it looked like in the operating theater and what it looks now, because occasionally we do accept a little bit of translation or angulation even in the operating theater. And then at 6 weeks, we look for callus, lots of healing, make sure that the fracture is healed pretty much completely. You will be able to see the fracture at 6, 8 weeks, even at 3 months, you'll be able to see the fracture. So if you do get a fracture follow up and you obtain an X-ray at 3 months, don't be alarmed that the report says that the fracture is still visible. As long as there's a large amount of callus, it's okay. The callus is holding the fracture. And by about sort of 6, 8 months, usually that's when the fracture starts to remodel, and by about a year, you wouldn't be able to see it anymore. Okay. And when I do monitor these children, especially the growth plate injuries, I do a 3-month X-ray. That's my sort of baseline X-ray that I want to compare that, let's say, in a year or something, so I can go back and compare what's going on. And then usually they do that till they stop growing, or they're about to stop growing. So in girls, it's usually about 14 to 15. In boys, it's about 16 years old. That's when they stop growing. And so we do that on an annual basis, or maybe every 18 months, just a plain X-ray to monitor the growth of the bone if we're worried about growth plate injuries. So in summary, children heal really rapidly, so you don't have to worry. Just if you get a fracture, by 6 weeks, usually they healed. Fracture will remodel, so you can reassure patients. If it looks bad, it will probably look much better. In about 6 months. And like I said previously, 6 weeks, most fractures heal. The lower limb takes a little bit longer. And most kids, because this is another question I get from parents, most kids don't really need physiotherapy. They'll do their own exercises. They can play. They actually very active. So, and they don't get stiff. So most of them don't need any physiotherapy. There's certain fractures I would send for physiotherapy if I'm worried, but 95% of them don't need anything done. Thank you.
Thank you very much, Igor. There's a lot to think about there, and that's incredible about some of the remodeling pictures. They were amazing. So on to our second speaker for the night. So we have Dr. Jerry Lin, who's going to talk to us about scoliosis. Jerry is completing his trauma fellowship at the Canberra Hospital, and he has dual training in adult and pediatric spinal orthopaedics. Jerry is due to travel to Oxford for a second spine fellowship. He must love his spines. And he will start practice in Canberra in 2027, focusing on adult and pediatric spine conditions and minimally invasive spine techniques. So thank you very much, Jerry, and over to you.
Hey, Leonie, thank you for having me. So this talk is going to be a very broad, principles-based talk on pediatric scoliosis. So we'll cover a wide range of topics. This is the overview. So we talk about the general approach when you see someone with scoliosis or you suspect scoliosis. We talk about prevalence, talk about the types of scoliosis there are, and some of the management principles. And in preparation for this talk, I spoke with a few of my primary care physician friends and Ally Health, and collated some of the top, most frequently asked questions that they have, like, when I find a curve, what do I do next? How fast do they progress? Do I need to send them to someone immediately? What are the red flags I need to look out for in the community? And what surgeries look like? How do they function after that? And also, I collected some myths throughout my training and my fellowship that I've heard from parents that are quite common. So as a general approach to orthopedics or to scoliosis, really, it's about finding that curve and finding out why they have the curve, whether it's part of a syndrome, whether it's part of a neuromuscular condition, and looking out for those red flag symptoms that I will get into in a little bit. It's about monitoring them regularly for progression and especially watching out for those periods of rapid growth, as scoliosis tend to get worse when the kids grow. And it's really about optimizing non-surgical interventions and avoid and delaying surgery for as long as practical, and really utilizing that MDT approach from the community to the GPs, allied health, physiotherapists, occupational therapists, brace makers, pediatricians in hospitals, all the way to subspecialty geneticists for patients with some more complex genetic disorders. So we know that scoliosis is very common in the pediatric population, depending on what you read, but around the world, it's agreed that it's probably around 3 to 8% of any pediatric population. And the definition of scoliosis is a lateral curvature of 10 degrees in the spine, but they often have a rotational component as well. So let's say if we take 5% as an example in the general population, that means in Australia right now, probably have around about 290,000 kids with scoliosis. And of course, majority of them don't need surgery or don't need any intervention. Many of them, we might not even notice they have scoliosis because they're very mild. There are many types of pediatric scoliosis. So we start with congenital, infantile, neuromuscular, neuroaxial, syndromic, idiopathic. Adolescent idiopathic scoliosis is by and large the most common. And that's a topic for a different talk. So when we say congenital scoliosis, it typically means that they're born with it, but not only that they're born with it, it means there's some congenital anomaly with the makeup or with the anatomy of their spinal column. So you tend to divide it into a failure of formation. So one segment of the spine either have not formed completely or have not formed at all. A failure of segmentation means when the spinal columns start to divide, somehow part of them have failed to divide. Often these kind of happen as a mixed picture. So you have part of the spine that have a failure of formation, a failure of segmentation. And this is an example. This is a child that we treated at the Children's Hospital in Randwick. And you can see this is a babygram of a, I think this is, by this time they're like a 2-month-old. You can see that this is there's a lateral curvature of the spine and a weird sort of gibbous kyphosis in the thoracolumbar junction. As we look down the spine, it all looks pretty normal through the neck, through the upper part of the thoracic spine, until you get to this point when you start to see the abnormality. So in this vertebrae, you have one pedicle here with one rib, two pedicles here with two ribs. This one down here is a butterfly, which means they're split down the middle, and there's a number of anomalies down here. So this is a pretty typical congenital scoliosis. Now, congenital scoliosis, they're often accompanied by a syndrome, a neuromuscular condition, or a genetic condition, but they don't always. There are quite a few kids running around with a single anomaly in the spinal column they are otherwise completely normal. Neuromuscular scoliosis, as the name suggests, it's associated with the underlying neuromuscular condition, and these are some of the common ones. And by far and away, the most common one is cerebral palsy in our community. And you can see that this is a list published by the Scoliosis Research Society that demonstrates the incidence of scoliosis in different neuromuscular conditions. In our community, CP is the most common. And as CP gets worse, as they go from 2 limbs involved to 4 limbs involved, the incidence of scoliosis goes up from 25% to 80%. If we dig into a little bit more about cerebral palsy, we think it's about a quarter of the kids or patients with scoliosis in their pediatric age will have scoliosis, and they get worse as they progress through their GMFCS scale. So the patients who are wheelchair bound almost all the time will almost definitely get some sort of scoliosis, and that's relating to the severity of their neuromuscular imbalance. And cerebral palsy really generates a very different curvature that we can see for these kids. So if we follow the spine again from the top, at the top it seems to be relatively normal through the neck. But as soon as it gets to the mid-thoracic spine and into the lumbar spine, you start to see a huge amount of rotation. So this is almost a front-on view of the thoracic and upper the thoracic and the cervical spine, but almost a lateral view. And you can imagine what they go through when their body rotates like that. And at the kids hospital, we see a lot of kids that presents like this. This is how they clinically present, and this is what their X-rays look like. And this, they can have traumatic. This is quite traumatic for them, quite traumatic for their carers, because it's very difficult to manage them in a chair, very difficult to manage their pain as their rib cages sort of start to impinge against their pelvis. The next type is neuroaxial scoliosis. Now, this is not really a type of scoliosis that you can diagnose, and that it's really more of a retrospective diagnosis. It means that the scoliosis is driven by a central nervous system pathology, and it's actually relatively commonly seen, especially when we find kids under the age of 10 with scoliosis. So these are the four really common, or relatively common causes. So Arnold-Chiari malformation means that their brainstem and their cerebellum starts to herniate through the foramen magnum into the spinal canal, and they will block CSF flow and cause subsequent neurological changes. Syringomyelia or syrinx means there is a pool of CSF fluid within the middle of the spinal cord, and they can be as simple as the one on the left or as complex as the one on the right. Spinal cord tumor, by definition, means there's some sort of tumor that's building within the spinal cord itself. And as a rule, if you find one of these in a patient and you send them to a neurosurgeon and then CNS causes are addressed, about a third of them will continue to get worse, a third will stay the same, and a third will get better. And it's really quite hard to pick which third the child is until they've done the surgery, they recover, and you kind of just watch them. Syndromic scoliosis means it's relating to a syndrome. And in our community, the common ones are Marfan's, Ehlers-Danlos, osteogenesis imperfecta, neurofibromatosis. And similar to neuromuscular scoliosis, there's some sort of underlying pathology as part of the syndrome that's driving the imbalance and driving the scoliosis. So they behave more like neuromuscular scoliosis, less like the idiopathic scoliosis. And finally, idiopathic scoliosis is the majority of the ones that we see, especially adolescent idiopathic. We still don't know what causes it, hence the name idiopathic. And it's broadly divided into early and late onset. Early onset is then subdivided into infantile, juvenile, based on the age of onset, and adolescent means older than the age of 10. And I have another talk about that. It's more specifically talking about AIS, maybe for our next education night. So last time I gave this talk, someone put their hand up at this stage and said, hey, but it's all well and good to learn about this, but patients don't really present in neat little packages of confirmed diagnosis. So we need to, in addition to the types, we need to know how to deal with them when one shows up in our clinic. So typically, this is how they present. You have a 13-year-old girl who presents to your clinic or your GP practice or physio practice with a posture issue that's noticed by parents at the beach. So this is incredibly common in our community, especially in the coastal cities. When the girls get to their 10, 11, 12, they go to the beach, they put on swimmers, and the parents look them from the back and say, hey, why is your shoulder up, a little bit up, and why is your pelvis a little bit tilted? So then we go back to our general principles. We got to find a curve. If there's one to find, we need to find out why they have the curve. We need to know how to monitor it, watch for the red flags, and how to optimize their treatment. So you organize an X-ray and you find, hey, there is a confirmed scoliosis, and that's what it looks like. So what's next? Well, the next is, sort of start thinking about whether this is an idiopathic curve or a non-idiopathic curve. And the whole of the work of the history, the examination, the investigation is about ruling out the non-idiopathic curves, the congenital, the neuromuscular, the neuroaxial, or the syndromic curves. And idiopathic is a diagnosis of exclusion. So only when you are satisfied that the way the patient looks, the way they present, everything looks like an idiopathic scoliosis, can you then say, all right, this is probably idiopathic, because this is where the management starts to diverge of, because idiopathic tend to be more predictable, and we have a lot of studies, a lot of data on how they behave. Non-idiopathic scoliosis, we also have a lot of data on the inability for us to predict where they go. So next thing is well, I guess the other way to think about scoliosis is think about them in a sense of typical versus atypical. And really, this is related to the red flags. And typical curves really is your adolescent idiopathic scoliosis. So your females, when they onset age of 10 plus with a right thoracic scoliosis, that's about really to really bring it down to the basics. This is the only real typical scoliosis that you see. Everything else is by definition a little bit atypical. So an early onset scoliosis can be atypical. If scoliosis in boys is atypical, especially over the age of 10, because there's 8 to 10 times more likelihood for a female to develop it for whatever reason. A left-sided thoracic curve in anyone can be pathological if they have any neurological changes. So the red flags are boys, neurological changes, if they're associated with significant pain, especially night pain, and if they somehow progress really, really rapidly. As a rule, anyone who has any atypical features in Australia in the year 2025 probably should get an MRI scan of their brain and the full spine to look for any neuroaxial abnormalities or neuroaxial pathologies that can be reversed. And we typically see them depending on where they are, whether they're close to a kids hospital, what the wait list is like, do they have access to a private surgeon? But typically 6 weeks to 3 months is relatively safe an interval for referral. So the next question that a lot of people ask is, how fast do they progress? Well, the answer is really, it depends, but we know that growth is the enemy. So as the child grows, so does most of the time their curve. So this, as you would know, is a growth velocity chart, and the charts, as you can see, whether you're a boy or a girl, it charts the velocity by which a kid will grow. So we have probably one of our highest growth velocity in between our ages 1 and 2 and 2 and 3. And then it gradually slows down till the age 10, 11 until we hit puberty, and that growth velocity increases again. So by definition, the earlier you are in making that diagnosis, or the earlier you are to have scoliosis, the more time you have to grow, and therefore the more likelihood you are to for the scoliosis to progress. And as a typical rule, as a general rule of thumb, we say boys grow to about the age of 16 and girls grow to about an age of 14. So there you go. The younger the diagnosis, the more likely, I guess not surgery, but intervention may be necessary. And some of the growth remaining indicators. So we see someone in the rooms or in the clinic, and we need to know, well, how likely are you to grow, or where are you in relation to your maximum growth velocity? So as we said, boys to 16, girls to 14 is a general rule. Looking at the parents and the parental heights is a good predictor as well. For girls, time of their first period is quite useful, both for scoliosis or like Dr. Policinski talked about in growth plate injuries, because we know that girls typically have their maximum growth velocity 12 months prior to their first period and about the 18 months after, and they typically stop growing 2 years after their first period. Shoe size as well. So the rule is if their feet are still growing, their axial skeleton will continue to grow as well. And there are a number of radiological markers that are probably more objective and more reliable. In orthopedics, we use more commonly the Grillage-Pyle left-hand X-ray. So these are sort of indicators that a radiologist can look at based on an atlas, based on a patient's X-ray, and can report that their skeletal age. Richter scale is another one, and it's particularly useful in spine, because as we get an EOS scan or a full standing spine X-ray, the pelvis is typically involved. So that's a really good indicator in when we take a history, examine a patient, look at the X-ray, and go, how much do we think you're going to grow? So the next most common question is, well, who do I send the patients to, and how urgently do I need to send it? And I guess most scoliosis are not that urgent and can be seen within 3 months, because sometimes we like to have comparison x-rays so we know how much they progress. So sometimes we even like to see them in 6 months, but 3 months is pretty safe. The only caveat to that is if they're really young, like if they have a congenital, somehow diagnosing a congenital scoliosis in the community, or if you know that they're about to hit their growth spurt, then we should probably see them a little bit earlier, as they may have a rapid worsening of their curve. Neuromuscular syndromic scoliosis probably should be seen in a tertiary pediatric center with a team, but the wait list is typically quite long, so 3 months is quite safe. Patients with confirmed neuroaxial abnormalities, say you see a boy in the community who's 12, who's got a left-sided scoliosis, and you get a MRI scan of their full spine and they find a syrinx. They should be referred to a neurosurgeon and a scoliosis surgeon relatively soon, because they will need an intervention, if not for the scoliosis, but almost certainly for the abnormality that you've identified. But we know that in practically speaking, timing of review is really heavily dependent on the availability of the clinics and whether they can access someone privately or not. The current existing referral pathways for Canberra, I think Canberra's referral primarily goes to Sydney Children's Hospital. So Dr. Angus Gray and Dr. Patrick Lim are the two pediatric surgeons there. You can either access them with ConsultMed, that's the Sydney Kids Hospital Network referral system, or through their private rooms. And as Leonie said, I'll be back in Canberra in 2027, so I'll be very happy to see anyone from 2027 on. So what does scoliosis surgery looks like? And that's a very broad question, because this is probably what an adolescent idiopathic scoliosis surgery look like, with lots of pedicle screws, lots of two rods, and they do extraordinarily well. Patients with AIS after correction can go back to almost all the sports. They lose some flexibility. They lose some sort of bending of their spine because the majority of it's fused, but they function extraordinarily well. Neuromuscular neuropathic scoliosis, less so. This is a bipolar construct that we use for wheelchair-bound patients to minimize the surgery. This is the anterior surgery. So there's not really a one-size-fits-all with scoliosis surgery, because they all are a little bit different based on their diagnosis, their background function. And this is the magic rod, the really famous magic rods that we put in kids that are still growing, so we can use the electromagnet to lengthen the rod as the child grows. So final thing is, I thought we'd give some practical learning points as a summary for each of the scoliosis. So congenital scoliosis, the learning points are they're very likely to progress because they are born with it. They have an anatomical anomaly with their spine, and they have so much growth left from age 1 to age 14 to 16. But it really then depends on the number of anomalies there are, where the anomalies are. So like if you look at a tree, if there is a bend at the bottom of the tree, the top of the tree is going to be looking sideways. Whereas if you have a bend at the top of the tree in a upper thoracic spine or a cervical spine, then it's probably not going to be as exaggerated. We typically follow them up really regularly with half-yearly or yearly x-rays. And the goal is to intervene as little and as late as possible to let them grow out to their full length, well, especially thoracic length. And we want to see these kids as soon as possible, as soon as you have made a diagnosis, and we need to monitor them really regularly, almost into adulthood. Neuromuscular syndromal scoliosis is a different kettle of fish. These people, so once you see them in a community, someone with Marfan, someone with cerebral palsy, then alarm bells should be going that, hey, we need to look at their back. We need to look, but not just the back. And cerebral palsy, we need to look at their upper limb, their lower limb, their hips, their knees, and their spine. And these patients should be treated in a NDT manner in a pediatric hospital. And we should see them as soon as the curve is observed, so we can watch them regularly. And the goals for managing them is very different. It's about optimizing their function and comfort. It's about optimized feeding and head position, especially for the ones in a wheelchair. It's about optimizing sitting balance and sitting tolerance, because for a child who is wheelchair bound, if they can't sit in a wheelchair for more than 2, 3, 4 hours a day, that means they're in bed for 20 hours a day, and that's very bad for their overall health, their mental health, for their carers. And it's about preventing pressure areas for these group of patients. Neuroaxial scoliosis, as I have talked about multiple times, is really about making that diagnosis. It's really about identifying what's atypical, or what the red flags when you see someone with scoliosis, and then organizing that brain MRI and spine MRI. As soon as you find something, refer them on, because they will need interventions as soon as possible. AIS is the most common that we see. It's about 8 to 10 times more common in female. It's almost always right thoracic. They almost always have rotation, so they have that rib and shoulder prominence. And as a rule, braces control progression, but really doesn't reverse the curve. And as a general rule, thoracic curves 220 degrees, you start 20 degrees or more, we start bracing. The curves greater than 50 degrees is when we start talking to them about perhaps considering surgery, because they will get worse. Not they will. They're likely to get worse into their skeletal maturity or into their adulthood. Finally, some of the myths that I've heard a lot of over my fellowship and during my training from kids, from teenagers, from parents, is scoliosis is not related to bad posture, sleeping positions, or heavy backpacks. And this might seem trivial, but a number of times we've been asked to write medical certificates for their kids to not carry a heavy backpack because it might cause scoliosis, is probably a myth. Back pain and scoliosis, there was a time 20 years ago when all the literature says you shouldn't have back pain with scoliosis. But now we know that probably 50, 60, 70% of patients with scoliosis will experience some form of back pain. But we also know that 50% of teenagers complain of some sort of back pain. So does the scoliosis cause back pain? We're not sure. Exercising is completely safe with AIS, especially. So we tell the patients that, hey, and the parents, that your back may look a little bit different, but structurally they're sound, they're strong. You don't need to avoid any contact activities. This is for adolescent idiopathic scoliosis. And we tell them that the brace or physiotherapy will not cure their curve. You can train yourself to make your posture look better, to minimize the appearance of the curve, but it probably won't disappear. And when curves get bad enough, they can continue to get worse as you get into your adulthood. And scoliosis is really not relating to any sort of dietary supplements or nutrition, especially in Australia. So that's the end of my talk. Really happy to take any questions.
That's great, Jerry. Yes, so there's a couple of questions, and we'll start off with Jerry. So the first one is, so it's talking about cerebral palsy. There is a defined screening recommended for hip dysplasia and cerebral palsy. What are the recommendations for screening via imaging with children with cerebral palsy?
As far as I know, I don't think there is a defined screening for backs, because we very often see in Randwick, we very often see kids that have had their hips screened, and then you incidentally found that they also have scoliosis, and then we get involved in the spine clinic. So I'm not sure. I'm very happy to look it up. But as far as I know, I don't think there's a screening program.
Would it be worth GPs screening children with doing a back x-ray for children with cerebral palsy just because they have cerebral palsy?
I think it's worth screening clinically. Like usually cerebral palsy kids, when they start to have a curve, they're pretty obvious. So if they can stand, as many of them can, then you can do an Adams-Fords bend test just to see what the back looks like. And if there are any clinical concerns, then getting an x-ray. If they're in a wheelchair, you can actually really easily just get the parents to hold them and lean them forward in the wheelchair, that you can watch the curvature of their spine from the back. So I think it definitely a high index of suspicion clinically. And if there's anything that you are worried about, then getting an x-ray is a good idea.
And what about limb length discrepancies. So someone's got a leg shorter, one leg shorter than the other. Can that cause a scoliosis, or just can look like a scoliosis?
Yeah, that's a really good question. So, yeah, with their multiple pelvic, hip, and leg length discrepancy issues, that the way the brain works is the brain doesn't like your head not over your pelvis. So, as part of our transition, sort of weight transfer, we like our head to be in the middle of the body, directly over the sacrum. So, as soon as you have a pelvic obliquity or leg length discrepancy, the brain actually says, well, we need to compensate somewhat by moving the center of gravity over to the middle and then causing the spine to curve. But in those instances, when you have leg length discrepancy, if you ask the patient to sit down, or if you do an Adams Ford's bend test, they actually unwind their scoliosis. So their back becomes straight. So that's I guess, the definition of a structurality of a curve. If a curve is structured, it means it has rotation. It means it doesn't unwind, either sitting or with a forward bend test.
So another question for you, Jerry, and then on to Igor. So I've seen a 11-year-old girl with a right thoracic curve with Cobb's angle of only 3 degrees. Would this be classified as a scoliosis, and should I monitor?
So we tried, so that because the definition of scoliosis is 10 degrees, so 3 degrees are probably more likely due to if they have sort of leaned one way or the other. That's quite common. We try not to make the diagnosis of scoliosis until they are sometimes even 10, 15 degrees, because at times making that diagnosis can have significant ramifications. So for example, if you get a diagnosis of scoliosis, you are not able to join the military, or certain jobs will not want to have you being involved in the workforce. And a scoliosis or a curvature of 10 degrees is really, really unlikely to progress unless you're part of a syndrome or neuromuscular condition. Then they are probably going to continue to get worse. But we don't make the diagnosis until they're at least 10 degrees.
Right. Thanks. Okay, Igor. With the buccal fractures, it was interesting to hear that the management of them has really kind of backed off a bit. So in terms of returning to sport, if you've got a bandage on, what do you recommend for buccal fractures?
Okay, thanks, Leonie. Yeah, so it's all to do with pain, I guess. So if the child comes back at 6 weeks and you squeeze the arm and there's no pain, then my feeling is they can get back into contact sports. Yeah,
Yeah.
but it normally takes 4 to 6 weeks for the pain to disappear. Some kids are pretty good even at 2 weeks. So if it's like a bit of a toddler, 4 or 5 years old, then usually by 2-3 weeks they won't have any more pain.
So back
But if
into
you're
the
talking
swimming
about
pool.
contact sports, like, the 10-year-olds, the 12-year-olds, usually they will take about 6 weeks before they're pain-free in the distal radius.
Right. Yep. What about things like swimming and non-contact sports?
Oh, look, that I usually tell them that once they're comfortable, they can get back into swimming and bike riding and running and things like that. Yeah, so that I'm pretty liberal about. But yeah, contact sports, I wait until they're really pain free, and when I squeeze them at the fracture site, they don't have any pain. Then I'm happy for them to start playing contact sports.
And what about lateral malleolus avulsion fractures? How do you manage them? Do you manage them with a moon boot, non-weight bearing, or is it again done on pain?
Yeah, so those some of them, so they normally like a Salter Harris injuries, the lateral malleolus in children, and so those I usually protect weight bear. So I usually tell they go into a moon boot, and I usually say non-weight bearing for 6 weeks. They can, if they're completely undisplaced, so if they're tender or they're questioning whether it's a Salter Harris injury, or then I let them weight bear, like protective weight bear. But if there is displacement, let's say you get about 10-15% of displacement, and we can see that it's a Salter Harris, then I usually not weight bear them, because that growth plate really needs to heal, and it takes about 4 to 6 weeks for that to heal. To be safe, make it 6. The children won't get stiff, or they won't have any problems with the boot.
Yeah.
So you always play it a bit safe with these fractures.
sometimes you get discharge summaries from the walk-in centre or ED where they've just got a little chip off their lateral malleolus and, you know, they're like weight bearers tolerated. So you get kind of conflicting advice
Yeah.
on these types of injuries.
If it's a little avulsion fracture, like a little
Yeah.
tip, like a flake, then
Yep.
that's more of a periosteal avulsion or little ligament avulsion. Those you can weight bearers tolerate it pretty much straight away. But when you look at if it's a distal fibula Salter-Harris injury, then you got to
It's a
protect that.
different story.
Yeah.
Yep. Yep. Thanks. And then you were talking about following people up who've had a growth plate injury and,
Mhm.
you know, x-raying them for a few years after the injury. What happens if 3 years down the track you do find that there's a delay in their bone growth?
Yeah, that's a good question. Yeah, there's reconstructive surgeries depending on you know, what what the problem is, like predicting what the problem is. So I had a patient, for example, who had a uh, undergrowth, or they had a ulnar injury. I think it was wired because it was very unstable, and she had a growth plate arrest on the ulnar, and her ulna was about 2 centimeters short. She, you know, we tried arresting, so you can arrest the other side. So, for example, you can go in there and arrest the distal radius physis. So you can do an arrest of that, so that the two bones don't overgrow. So both of them stop growing. That didn't work because she was about 13 years old, so she was about to stop growing anyway. But at the end, like by the time she finished growing at the age of 16, I got an X-ray, and there was a 2 centimeter difference between the radius and the ulna, and the ulna was short, so you have to do an ulnar lengthening procedure. So you basically do an osteotomy, you lengthen the ulna, bone grafted, plated, and she did quite well. And you can do the same thing with overgrowth. So if something's overgrown, then you can shorten the ulna or the radius. So corrective osteotomies are quite common.
Right. And whose responsibility is it for doing those yearly x-rays? Like, is it something that GPs
Uh,
should put reminders on, or?
Look, you potentially can. I mean, the thing is, it's about recognizing the problem, though. So I wouldn't expect a GP to recognize that there's an overgrowth or an undergrowth. And look, in the reports can be a little bit like the radiology reports can be a little bit misleading as well. So I think at the end, I think the onus really falls down onto the surgeon that's been managing this. And if there is problems, then I think the surgeon should really manage and follow that up. Like I see a couple of my kids, you know, yearly, just with X-rays, just to make sure it's fine. Because I don't expect you to sort of know that type of thing. You got to really see it to know what you're looking at the X-ray, and compare the old X-rays to the new X-rays.
Yep. Yep. Right. So now a question about x-rays. So this one's for you, Jerry. So my own personal experience is I had a girl who looked like she had a scoliosis. She was about 12 when I first saw her. We got a spine x-ray and it was reported as no scoliosis. And then subsequently she's been diagnosed with Marfan's, and she does have a scoliosis. Do you have any advice about trusting x-rays, which x-ray place? I know you probably can't say which x-ray place to go to, and whether if you notice a scoliosis, do you x-ray first, then refer, or just refer?
I think to answer the second question first, Leonie, I think if you notice scoliosis, you should get a ER scan first because that's probably the most reliable. I am not sure if there's maybe some of the audience might know if there are any practice in Canberra that offers EOS scans. It's a very low dose X-ray for the full spine. And going back to your first question, I think if you see an X-ray and you can't decide whether there's scoliosis or not, it probably is very, very mild. Even if there was one, that's not warranting too much concern. But certainly, getting another X-ray in 6 months' time, if they compare them, if they look the same, then you've established that over 6 months they haven't progressed at all, and that's really reassuring. Compared to but as you said, this particular patient of yours has Marfan, so you're already at a higher sort of awareness, and the alarm bells are already going off that they may develop scoliosis. So that's something that you probably want to get back, at least check them every year or so clinically.
The audience have come back with an answer. CIG does EOS scans.
Perfect.
Yeah. And one more question. So what about Sherman's disease? So do you do much about that?
So Scheuermann's is a completely different kettle of fish, and Scheuermann's is much, much more common in boys than girls, and typically about the age of 14 to about 18. Scheuermann's is very different from scoliosis from a natural history point of view because in most adolescent idiopathic scoliosis, the long-term 50-year study shows us that they actually function like any other members of the population. So they have jobs the same. There's no difference in occupation, no difference in whether they get married or not. Very little difference in back pain. Well, that's a bit controversial, but by and large, and very, very sort of similar pattern in terms of psychosocial development. Where Scheuermann's is a different story. There is sort of long-term studies that tell us they're less likely to have a family, less likely to be married and have kids, and much more likely to have psychosocial issues, especially when the curves get quite bad. So Scheuermann's is managed a little differently. Typically, by about 70, after 70 degrees, you start to think about surgery because they start to really, really hunch over, and patients typically don't like it. As they get to about 90 to 100 degrees, it becomes really difficult to maintain your horizontal gaze. So you have to really, really, really lift your head up high to compensate for the thoracic kyphosis. So we're more likely to intervene, but the surgery for Scheuermann's is more difficult. Treatment, deformity correction for kyphosis is more likely to fail and has more risks in terms of neurological change compared to your typical AIS.
Right. Yep. Thank you both so much. That was really interesting, and there's a lot of stuff for us in primary care to think about and to approach orthopedics a bit differently. So very, very useful, and we might take you up on a talk later on adolescent idiopathic scoliosis. That would be useful, and we'll find a topic for you too, Igor.
Thank you so much.
And maybe we could get Blaze back for to talk about gait abnormalities as well. So something for next year. Thanks to everyone for attending tonight, and thank you to the speakers. We're going to put the recording up on our YouTube page, and please feel free to report 1.5 hours of educational activities to your CPD home at this pointy end of the year. And we would love it if you could fill out the evaluation surveys. That would be great. We'll send them out to you. And that's it for tonight. Thank you both very much. Thanks.
Thank you very much.
Thank you very much. Have a good night, Igor.
Thanks.